Hi girls, today we are going to do special testing and taping and bracing for the foot, ankle, and lower leg. So, purpose of special testing obviously has not changed, to isolate the specific body part to test the integrity and determine the severity of injury. So if we're thinking an ankle sprain, we want to isolate those two ligaments, the anterior talofib and the calcaneal fib, that we think have been damaged on an inversion ankle sprain. We're trying to mimic the mechanism of injury, which would be an inversion movement, and the functional stability. You should be able to reproduce pain, weakness, or abnormal motion depending on which test and injury you are looking at. So manual muscle testing, this is obviously for if we believe there is a muscle strain. In the ankle, if you believe the tibialis posterior has been strained, the movement you are testing is inversion. You are going to have them resist the movement of inversion, or you are going to resist as they perform inversion. And if there is pain or weakness, that would indicate a muscle strain to the tibialis posterior. Manual muscle test is graded on the scale of 1 to 5, and then the muscle strain is graded on the scale of 1 to 3. Actually, I think manual muscle testing might be 0 to 5, but same difference. Eversion or the peroneus, dorsiflexion is the tibialis anterior. Plantar flexion is the gastroc with a little help from the soleus. In the toes or in the foot, for the toes you have extension and flexion. And then obviously the big toe is the extensor hallucis. The pinky toe for flexion would be the digiti minimi. So the compression test. This is for a suspected fracture of the tibia or fibula. The patient's laying supine, you're placing one hand on the medial below where you think the fracture is and one hand on the lateral. You're going to squeeze together, pushing the two bones together. As you push them together below the fracture site, they should move apart at the fracture site. If they are broken, that should not feel good. And that test should elicit pain. If there is a positive test, obviously we would refer for x-rays. Thompson test. Make sure, go to the original PowerPoint that I posted on Google Drive and make sure you click on the hyperlinks to watch these tests on YouTube. I really want to make sure you do that so you can see how these are being performed. This one is a really cool one. So this is for the Achilles tendon. Excuse me. Patient is laying prone, which is face down on the table with their foot hanging off the end. You're going to squeeze the mid-calf and the foot should move into plantar flexion. If there has been a rupture to the Achilles tendon, if it is no longer connected, when you squeeze the mid-calf, first of all, you will probably see a ball there. It will feel painful, but also no movement will occur because the Achilles tendon has been severed. It's no longer connected to the foot. Therefore, it cannot move the foot. It is important that the patient is completely relaxed while performing this test so that you get an accurate result. The anterior drawer, I believe, for this test and the Thompson test, click the link in the PowerPoint, and I think I have indications to show you what a positive test looks like as well. Those are pretty cool. So again, make sure you click to watch these videos. So the anterior drawer is for the integrity of the anterior talofibular ligament, which is one of the ligaments commonly injured in the ankle sprain. So the patient's laying supine with their foot hanging off the end. You're grasping the heel in one hand, stabilizing the ankle. And then you're applying an anterior force with the other hand. So one hand is cupping the heel, the other hand is pushing down on top of the lower tibia and fibula. You're pulling the heel forward, noting the amount of movement. So very similar to the anterior drawer, you are trying to get the foot to come forward. If there is an excessive amount of movement, that demonstrates that the ligament is either stretched or no longer connected. So, Taylor tilt test. This is for the calcaneofibular ligament, which is the other one injured in an inversion ankle sprain. And to test the deltoid ligament, which is what would be injured in an eversion ankle sprain, which is much less common. But it still could happen. So, patient is laying supine, you're placing the ankle into anatomical position. So, what that means, when you're typically laying supine, the ankle will naturally fall into plantar flexion. So, you're going to have to bring it back up a little bit into a little, not full dorsiflexion, but again, just back to neutral, to anatomical position. With one hand on the heel, you are inverting and everting the ankle. So, you're going to turn it in, you're going to turn it out. When you invert the ankle, you are stretching the calcaneofibular ligament. And if you can invert excessively, or if they experience pain, that would be a positive test that that ligament is stretched or damaged. When you evert, you are testing the deltoid ligament, which is on the medial side. So you're stretching it. And then if you can get excessive movement or pain, that would indicate that the deltoid ligament has been stretched or torn, most likely from an eversion ankle sprain. Again, make sure you are watching the videos. So, for taping, again, the purpose is the same. Restrict movement or provide additional support. For the ankle tape, we have obviously already learned this one. We have learned our ankle tape for a typical inversion ankle sprain. When we are taping for an inversion ankle sprain, you are pulling them into eversion and dorsiflexion. Because we want to prevent the movement of inversion and we want to restrict that movement. So when you are taping for an eversion ankle sprain, which is the much less common but still can happen, you are pulling neutral on the horseshoes and stirrups. Okay, we never want to pull them into inversion. So you would assume if you're taping for an eversion ankle sprain, we want to prevent the movement of eversion, therefore pulling them into inversion, but we don't. If we pull them into inversion, what are they going to do? They are going to get an inversion ankle sprain. Okay, so we do not want to put them in the position to have another injury. We are going to pull neutral, which means you would just, instead of pulling medial to lateral, you just pull straight back. So start on the heel or wherever and just pull straight back instead of pulling medial to lateral. Because again, we do not want to pull them into inversion and cause another injury. So an arch tape. This would be for a medial arch strain. You have the three arches of the foot, medial, lateral, longitudinal, if you remember from your picture. So if they have a medial arch strain, it is most likely a fallen arch or a flat foot. that you are trying to tape for. So you're using the inch or the half-inch tape, so that's the skinny tape. You are applying an anchor strip to the ball of their foot, which would be the heads of their metatarsals, and then in a teardrop pattern, you're going to go down the lateral, which would be pinky side, and up the medial. So start here, down lateral, up medial. Start the next one, down lateral, up medial. That's the teardrop pattern. Repeat for all 5 metatarsals, and then you'll apply closure strips, which actually this picture doesn't show you, but closure strips will go here. You can actually video or Google or YouTube a video for this as well. It might be helpful. So, shin splint tape. Technically, you can tape for shin splints. I would never tell this information to athletes, specifically cross-country runners, because there is no feasible way to tape shin splints for an entire team of cross-country runners, because obviously most all of them have shin splints. But I just want you to know that it does exist. It basically accomplishes the same function as a brace. And a brace is more economical to use and also more time consuming, and the athlete can take their brace anywhere, as opposed to if they're traveling or they're running on their own, they don't have access to you to tape them. But basically what you're doing is you're applying 2 anchor strips, one on the medial, one on the lateral, and then you are just doing surrounding, overlapping strips of tape from the distal to the proximal tibia. It just applies pressure and support. It doesn't restrict any movement. You do use the white tape. You can use slightly stretchy tape, but again, it's a very uncommon tape job. Most people do not tape for this. They just use a brace, but again, I just want you to know that it exists. And we are done with the foot, ankle, and lower leg. Make sure that if